everyone. My name is Perry Lockhart, and I am the co-chair of the Nova Scotian Alcohol Policy Coalition, also known as NSAP. NSAP came about from people interested in alcohol harm reduction policy, just casually meeting to stay in contact and up to date on the impacts that alcohol has in our communities across the province. In January of 2022, we chose to formally become a coalition with the mission of collaborating to protect the health of Nova Scotians by strengthening and influencing alcohol policy to shift cultural norms and reduce alcohol-related harms. NSAP is rooted in our values of shifting culture, reducing harms, reducing risk, policy action, and enhancing protective factors. If you would like to learn more about NSAP, please visit our website, novascotiaalcohol.ca, or email us at novascotiaalcoholpolicy@gmail.com. Thank you all again for joining this webinar today, and we'll start things off with a video that we have called See What I See. And I'll now pass it off to Tina to play the video.
My name's Remy. I'm an ouch kid. I'm 12 years old and I've already been exposed to hundreds of ads and pictures of alcohol. Next year I will turn 13, which is the age that most kids in Nova Scotia will have their first drink. When my friends drink, we are more likely to experience and cause violence. We are also more likely to get injured, end up in the hospital, and do poorly in school. Alcohol ads encourage kids like me to drink younger and drink more.
Help protect Nova Scotian children from the bombardment of alcohol advertising. Take action. Get involved.
Thank you, Tina, so much for playing that video. We'll send the link to where you can find that video in the chat throughout the webinar today. I'll now pass it over to Bella to start us off with the presentation.
Thanks, Perry. And hello, everyone, and welcome to our tailored presentation for the Nova Scotia Alcohol Policy Coalition. Thank you for being here today. I'll just briefly introduce our speakers for today. So Dr. Norman Giesbrecht is an emeritus scientist with the Institute for Mental Health Policy Research at CAMH in Toronto and was a founding investigator on the CAPE project team. He has served on numerous national and international teams over the years, and his career has been dedicated to producing high-quality evidence-based research to reduce and prevent alcohol-caused harms. Dr. Mark Asbridge is a professor with the Department of Community Health and Epidemiology at Dalhousie University, Nova Scotia. Mark has been a co-investigator with the CAPE project on all 3 iterations to this date. Mark's areas of expertise include impaired driving countermeasures, minimum legal drinking age, as well as alcohol and youth. My name is Bella Priori, and I'm a researcher with the Canadian Institute for Substance Use Research, or CSIR. I was heavily involved in the data collection and stakeholder engagement for the CAPE project. I've also been involved with various internal and collaborative projects at CSIR surrounding the topic of drug and alcohol policy in Canada. I'll just first start by doing a quick territory acknowledgement. CAPE is a Canada-wide project that is hosted by the University of Victoria and BC and the Centre for Addiction and Mental Health, CAMH in Ontario. We acknowledge and respect the Lekwungen peoples on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanish people whose historical relationship with the land continue to this day. I know that most of you folks today might be from Nova Scotia or elsewhere, so please feel free to share your own territorial acknowledgement in the chat if you would like. Next, we'd like to thank our funders and supporters. Please note that the views and opinions expressed as part of this presentation are those of the CAPE project team and do not necessarily represent those of our funders or other organizations acknowledged. I'll just give a quick outline of what we'll talk about today. This presentation will provide a brief overview of the CAPE project and policy domains, as well as present results and recommendations specific to Nova Scotia to improve alcohol policy and thus reduce harms. Because we can't cover everything today, the domains we'll be focusing on in this presentation will be physical availability, marketing and advertising, and health and safety messaging. So what does CAPE offer? CAPE provides a rigorous assessment of how well each level of government in Canada is implementing policies proven to reduce harm from alcohol use. This is the third time the assessment has been performed and includes all provinces and territories and the federal level. Specifically, CAPE offers accessible, evidence-based, up-to-date information for policymakers, researchers, and NGOs, amongst others, systematic policy comparisons between Canadian jurisdictions and over time, a platform for informing the public about effective alcohol policies, a mechanism for keeping a public health approach to alcohol policy on government agendas, and a community of practice with more than 350 members facilitating learning events and knowledge exchange. This is a quick overview. In 2020, people in Nova Scotia consumed the equivalent of 481 standard drinks of alcohol per person aged 15 plus. Alcohol led to 571 deaths, 2,889 years of productive life lost, and 44,172 hospital admissions. The economic cost of alcohol in Nova Scotia was estimated to be around $652 million. The net revenue from alcohol in Nova Scotia in 2020 and 2021 totaled about $432 million, resulting in a deficit of approximately $219 million. So it's clear that the cost of alcohol exceeded the revenues. The next slide presents the alcohol deficit in a bit more detail. Using data from StatsCan and the Canadian Substance Use Costs and Harms, the CSUCH study, we see that every province and territory in Canada runs an actual deficit from alcohol. The last row in this table shows the loss per standard drink. In short, alcohol sales do not pay their way. The WHO recommended tightening alcohol regulations during the pandemic with cost-effective and easy-to-implement policies to reduce the alcohol attributable burden of disease during a time when much of the population was very stressed and anxious. But we observed kind of the opposite, a lot of relaxation of these regulations. There were many policies in place to ease the accessibility of alcohol. For example, the expansion of alcohol sales in grocery and convenience stores and online, as well as extended trading hours, alcohol home delivery by third parties like Uber Eats, and alcohol takeout. In addition, we saw continued decline in government-run outlets, for example, in Ontario, BC, and New Brunswick, with movement towards privatization. For example, Saskatchewan became fully privatized. Some more positive trends included the greater interest in minimum pricing policies and alcohol sales taxes in some jurisdictions, for example, Newfoundland and Manitoba, and provincial and territorial alcohol strategies and action plans actually being released and in development in some jurisdictions, for example, Newfoundland, Northwest Territories, PEI, and Saskatchewan. This slide shows kind of an overview of the CAPE process. So CAPE follows a rigorous methodological process, which involves developing and then applying the scoring rubric in order to produce CAPE scores. The rubric is a template that details the policy indicators, which we collect and score data. These indicators are considered the best practice and are grouped into policy domains. The domains are based on broad policy areas with well-established evidence showing positive impacts for public health. As the research has evolved, so too have the policies included in CAPE. So there are now over 300 indicators evaluated as part of the CAPE. Approximately 210 provincial, territorial, and 93 federal. Updated evidence, such as for labels and pricing, informed the CAPE 3 domains and indicators, which resulted in new domain rankings compared to the CAPE 2.0. It's important to note that because of this, the results are not directly comparable between CAPE 3 and CAPE 2, as the evidence and policy indicators are updated each time, but they reflect the overall direction of government approaches to alcohol policy in addressing alcohol harm in Canada. A more detailed description of the project methodology and summary of the evidence for CAPE project policy domains is available on the CAPE website. Before we move into the results, here's a quick look at the policy domains included in CAPE 3.0. So there's 10 domains included in the federal assessment and 11 domains included in the PT assessment. The stars here indicate the domains that we will be presenting in detail today. Details of the 300 plus CAPE indicators can be found in the scoring rubrics. It should be noted that when presented in the various knowledge products for CAPE, the domains will be presented in rank order based on the weighting of effectiveness and scope, i.e. resulting in the highest overall impact. For example, listed first here is pricing and taxation as the most heavily weighted domain in CAPE. This is because policies such as minimum pricing, indexation, alcohol sales taxes, and retail markups are some of the most effective strategies that reach a large proportion of the population and have a significant impact on reducing consumption and alcohol-caused harm and social harms. It's important to remember that the policy domains assessed by CAPE form part of a comprehensive and synergistic approach to preventing and reducing different types of alcohol harms. So again, today we'll dive into physical availability, marketing and advertising control, and health and safety messaging. I'll now pass things over to Norman. Sorry, I'll now pass things over to Norman.
Thank you. Can everyone hear me okay?
Yeah, we can hear you.
Thank you. Okay, the average CAPE score across all provinces and territories was 37%, with the highest score of 44 for Manitoba, Quebec with 42, and Newfoundland with 41%, which was largely due to their pricing policies, which is the highest, as Bella just said, which is the highest weighted CAPE domain, pricing and taxation. Nova Scotia's overall score was 38%. Next slide. So let's look at this Nova Scotia's results by domain, and you can see that there were some scores were higher than other treatment and screening interventions, for example, and monitoring and reporting, and impaired drinking and driving countermeasures. We should note that treatment indicators measure the existence of services only, not quantity or quality of service. Next slide. The CAPE scores that we just presented reflect the performance of each province and territory according to the best practice for alcohol policy as captured in the CAPE scoring rubric. These are pretty tough standards, but we also analyzed the policy data to see which score could be achieved by any jurisdiction if they were to implement all the best or near best practice policies that were currently in place somewhere in Canada. So these are the best practices, not as judged by the CAPE team, but by comparison to provincial and territorial peers. We call this the best existing policy score. If Nova Scotia implemented all of these, it would result in a best existing policy score of 80%, which is an A-. An important point is that that all really good alcohol policies are achievable by adopting best practice of their peers. Next slide. So we're going to take a closer look at Nova Scotia for these three CAPE domains. Next slide. Physical availability refers to the number of off-premise retail outlets, that is liquor stores, and on-premise licensed establishments, that is restaurants and bars, in relation to the size of the population. Trading hours and days of these outlets and establishments, where alcohol outlets and establishments can be located, and which type of businesses are permitted to sell alcohol. Limiting physical availability of alcohol with reduced alcohol outlet density and trading hours is a key population level intervention that can decrease consumption and prevent alcohol-related harms. For example, Ontario has a low off-premise density and set a voluntary cap on grocery store licenses. Takeout and home delivery increase the spatial and temporal availability of alcohol and has been associated with an increased consumption and harms. Next slide. Here we see the average scores for physical availability across Canada was 40%, and Nova Scotia scored 32%. Nunavut scored the highest in this domain for lowest on-premise and off-premise outlet density. Saskatchewan scored high for having legislated off-premise density limits that take into account population into consideration. Next slide. The blue bars for off-premise. We looked at whether there was a provincially or territorially mandated limits on off-premise outlet density, including private, government type, run, and ferment on-premise outlets. For example, limits based on population density or number of outlets. We looked at outlet placement, for example, mandated distances from schools or community centers. For off-premise, the density cap was defined as 2 outlets per or fewer per 10,000 people aged 15 and older. In terms of hours, we looked at whether hours of alcohol sales were mandated and how they compared to ideal of not before 11 a.m. or not beyond 8 p.m., as well as having fewer than 7 days of sale per week, open less than the maximum possible hours of operation per week. Orange is on-premise with regard to a bar or restaurant. The same concepts as for off-premise outlets. The density cap for on-premise was defined as 15 licensed establishments or fewer per 10,000 people aged 15 and older. The indicator was scored against the ideal of the hours of sale not extending beyond 1 a.m. following day. And also there were no discretionary exceptions or extensions granted to the hours and days of sale, such as extending hours of operation for community events. The gray refers to home delivery and takeout. Takeout and home delivery increase the spatial and temporal availability of alcohol, particularly to minors. We looked at whether there were regulations prohibiting home delivery of alcohol for off-premise retail outlets and on-premise establishments, or requiring that alcohol home delivery be provided only by the retailer or licensee with a mandatory food component, rather than a third-party delivery service such as Uber Eats. The requirements about purchase of food must be well established and be adequate. Next slide. Blue, off-premise. The level of population-based outlet density in Nova Scotia is twice the recommended density of 2 outlets per fewer per 10,000 people. There are no set density or placement limits for any premises. Nova Scotia does not have regulated powers to set population level limits on outlet density and placement of off-premise outlets. The hours of sale extend longer than recommended across all premises. Orange, on-premise. The level of population based on on-premise outlet density in Nova Scotia is almost double the recommended density of 15 outlets or fewer per 10,000 people. There are no limits on the density of on-premise establishments, and there are some placement limits, schools and churches. Hours of sale extend beyond the recommended 11 a.m. opening time and 1 a.m. following day closing time, but they are near the recommended hours. Gray, take home and home delivery. A Nova Scotia alcohol home delivery, including a third party, is permitted. On-premise alcohol takeout and delivery is permitted in Nova Scotia. However, there is a defined food component required that is set in regulation. Next slide. Here are some recommendations. Set population based outlet density and place limits on for all premises. Reduce and legislated maximum trading hours allowed per week. Restrict alcohol sales before 11 a.m. and after 8 p.m. for off-premise outlets and 1 a.m. for on-premises establishments. Prohibit alcohol takeout and delivery included by third party from all establishments. If Nova Scotia implemented all the best existing physical availability policies across Canadian provinces and territories, their score would increase to 82%, which is A- from 32%. Thank you. I'm now going to turn it over to Mark.
All right. Thanks, Norman. And hello to everybody from Nova Scotia, where we're experiencing our first, as I look out the window, snowstorm of the year after being in shorts and mowing my lawn a couple of days ago. So what a weird time. Anyways, hopefully it won't last and everybody can get home safely if they're not at home already. So I'm going to talk about marketing and advertising controls, as well as messaging, health messaging. So just to give you a bit of an overview of marketing and advertising controls, a ban or comprehensive restrictions on alcohol marketing is one of the most efficient policies for reducing the harms caused by alcohol. It's efficient in large part because of its reach. It reaches sort of the consumer directly and, you know, is sort of activated by being present. So which makes it more efficient than some other types of approaches. Restrictions could include volume, content, and placement of advertisements, as well as price-based promotions like sales, alcohol sales kind of promotions. Effectiveness is contingent on restrictions applying to all advertisers and an independent regulatory body that monitors and enforces restrictions. And so the key piece there being an independent regulatory body, not embedded within the Alcohol Commission within the province. Next slide, please. So here we can see that the average score for marketing and advertising across Canada was about 33%, but in Nova Scotia, the score was 43%, which is higher than average. Nunavut scored highest in this domain at 56%, which is still a D, but 56% for its robust advertising restrictions paired with strong policies for enforcement of those advertising restrictions. Manitoba also had higher scores for advertising restrictions and having an independent online complaint system, which was specific to marketing and advertising violations. Next slide, please. So this slide goes into a bit more detail about which policy indicators were assessed for marketing and for advertising. And again, we have two different colors here. We have blue for advertising restrictions and orange for enforcement of advertising restrictions, which you can see. So in terms of the blue advertising restrictions, this can include controls on the volume, content, and placement of advertisements, as well as restrictions on price-based promotions, the prohibition of alcohol advertisements by non-licensees or third parties, and whether the restrictions apply to all advertisers and not just government retailers. In terms of enforcement of ad restrictions, this looks at whether there is a mandatory independent pre-screening process, as well as an independent enforcement authority. And if penalties for violations are commensurate with the severity of the violations and whether they escalate with repeat violations. And lastly, are the violations listed and publicly available for people to see. Next slide, please. So here's a closer look at the policies Nova Scotia currently has in place. And so again, blue is the advertising restrictions. So there's a mixed bag here of positives and negatives. So for advertising restrictions, Nova Scotia scored high among the provinces and territories on the comprehensiveness of marketing and advertising restrictions. On the downside, there are no restrictions on the volume of advertisements allowed across media or advertisers, and only some placement restrictions, for example, where the majority of the audience is not of legal age. On the plus side, Nova Scotia does have content restrictions that go beyond the CRTC code for all media types, but there are currently no bans on price-based promotions advertising cheap drinks or volume-based discounts. However, positively, advertising by non-licensees or third-party advertisers like DoorDash or Uber Eats is prohibited, and the restrictions apply to all advertisers. If we looked at enforcement of these advertising restrictions, on the downside, enforcement of ad restrictions, there's no mandatory pre-screening of alcohol ads across all media types or advertisers, and there's no independent online complaint system run independently from the alcohol industry and alcohol advertisers. However, there are penalties for advertising violations that are commensurate with the violation, and they do escalate for repeat offenses. And there are publicly available listings of violations, which advertiser name and the nature of the violation are presented. Next slide, please. So if we were to look at some key marketing and advertising control, key recommendations for this, two in particular is one is to implement restrictions on advertising quantity, for example, ad bans and volume restrictions, as well as placement in terms of physical location and price-based promotions for all advertisers, for government retailers, non-licensees, or third parties. And that this should encompass all media types, whether it's online and social media as well. A second recommendation would be to appoint an independent health-focused enforcement authority to conduct mandatory pre-screening of alcohol advertisements, as well as to host responsive online complaint systems and enforce penalties applicable to government and private advertisers. And so if Nova Scotia implemented all the best existing marketing and advertising control policies across Canada and the territories, they could increase their score to 72%. Next slide, please. So for the second domain, I'm going to speak about health and safety messaging. And again, I just want to give you a bit of an overview of this domain. So health and safety messaging can include things like alcohol warning labels, on-site signage at liquor stores and on-premise establishments, including restaurants and bars, and jurisdiction-wide health and safety campaigns. So some examples of this include the mandatory warning label program that was introduced in Yukon and the Northwest Territories, and BC's The Proof campaign about alcohol and cancer. And so Yukon and Northwest Territories was sort of an initial example of the use of warning labels. And in fact, it existed, it was quite successful, but was pulled back actually due to litigation threats from industry. This type of messaging provides consumers with critical information, allowing them to make informed choices about alcohol consumption. So we do this for everything we eat. We provide food warning labels and product ingredient labeling on all products we sell. We simply don't do this for alcohol, and it's a little bit odd why that's the case, but that's the case. So there's been particular interest in warning labels over the past couple of years as primary tools for raising awareness of health risks, such as alcohol's contribution to cancer and chronic diseases, which are, for the most part, not well understood by many Canadians. Campaigns led by government health agencies can be particularly effective, as they are perceived as one of the most trusted sources of health information and do not hold vested interest of alcohol industry. And this is important because we're in I would call an infodemic for many things, where we are having competing information sources and trying to sort out the valid from less valid pieces and sources of information, fact from fiction. Next slide, please. So here we can see that the average score for health and safety messaging across Canada was 13%. So nationally, we don't do a very good job with this. And Nova Scotia scored 2%. Alberta had the highest score at 37%, and they received points for having a mandatory prominent on-site signage requirements that include health messaging related to pregnancy and minimum drinking age. They also run a comprehensive ongoing health and safety campaign on alcohol and health, as an example. Excuse me. Next slide, please. So here some indicator scores from Nova Scotia. There's blue, orange, and gray. Blue refers to status and quality of product labels. orange on-site health and safety messaging for all premises, and gray is health and safety campaigns by health ministries and departments. Obviously, there's the variations on how present these are in each jurisdiction. We look at whether, for blue, we look at whether there is legislation in place allowing for enhanced alcohol labeling components on containers and mandatory evidence-based alcohol warning label messages, standard drink information, national drinking guidelines, and calorie or caloric information as a manufacturer requirement on product labeling. And we assess the adequacy of labeling components. For the on-site health and safety messaging for all premises, we looked at whether there's a mandatory off and on-premise evidence-based health and safety messaging on a variety of topics, for instance, cancer or other health risks, acute injury, violence, youth, impaired driving, and so forth. And whether there's adequate information to support informed consumer health decisions. And in terms of health and safety campaigns by health ministries and departments, we assessed whether there are ongoing annual health and safety campaigns specific to alcohol on a variety of topics that are run by the health ministry department. We also look at whether campaigns were developed and funded independently from the alcohol industry and from alcohol industry corporate social responsibility organizations. Details of the specific best practice policies for each of these indicators can be found in the scoring rubric, as well as the best practice policy leaders table at the CAPE site. Next slide, please. So in terms of health and safety messaging in Nova Scotia, again, in terms of status and quality of product labels, we need specific legislation in place that allows for enhanced labeling components. There's no currently required product labels with information about health risks for, again, cancer, standard drinks, etc., and national alcohol guidance or calorie content. In terms of on-site health and safety messaging, we have no mandatory signage about alcohol use to be prominently displayed at off-premise outlets nor on-premise establishments. There is no mandatory on-site health and safety messaging for off-premise nor on-premise establishments as well. And in terms of health and safety campaigns by health ministries, there are no ongoing health and safety campaigns led by ministries of health that are specific to alcohol and go beyond those limited to the holiday season, particularly the Christmas time. So that is it for me, and I'll turn it over to Bella again. Oh, or do I have, sorry. Pardon me, I guess I have one other slide, I guess. So a key recommendation is for Nova Scotia to implement enhanced alcohol labeling as a manufacturer requirement and mandatory on-site health and safety messaging, including signage, posters in all premises, and so forth. Labels, signage, and messaging should include a variety of evidence-based warning messages, including cancer risk, standard drinks, and so on, and be prominently displayed and accompanied by pictorials, rotated across products, and support consumers in making informed decisions about product use. And finally, need to deliver a variety of minister-led alcohol health and safety campaigns at least annually. And if Nova Scotia implemented all best existing health and safety messaging across policies in Canada's provinces and territories, their score could increase from 2 to 50%, but which shows we can make improvements. But I guess nationally, again, this is not an area of strength in Canada. I apologize, and now I'll turn it over to Bella.
Thanks, Mark. Yeah, so after all that, here are some overall examples of what Nova Scotia is doing well. So there is a minimum prices for all alcohol sold and some of the highest off-premise minimum prices in Canada. Moreover, the off-premise minimum pricing is automatically indexed to inflation and tied precisely to ethanol content for beer specifically. Nova Scotia has legislated restrictions limiting placement of on-premise outlets near schools, hospitals, or similar institutions. Home delivery of on-premise alcohol is prohibited. There are also restrictions on takeout alcohol, for example, a clearly defined food component set in regulation. Policies meet or are really close to the recommendations for graduated licensing programs, within the impaired driving countermeasures domain, compliance checks and penalties within the liquor law enforcement domain, and the comprehensiveness of the monitoring and reporting systems. Just to note, there was an alcohol harm surveillance system possibly under development, but it wasn't in effect at the time the CAPE data was being collected. Lastly, here are just a few examples of recommendations for Nova Scotia for some of the other alcohol policy domains that we didn't cover today. You can also see page 3 of the results summary for Nova Scotia for detailed recommendations for all 11 of the policy domains. So under pricing and taxation recommendations are to increase legislated minimum prices for all alcohol sold to recommended rates, tie precisely to ethanol content for all beverage types, not just beer, extend automatic indexation to on-premise, and tax alcohol at a higher rate than other consumer goods. A best practice example is that Nova Scotia and New Brunswick index all of their off-premise minimum prices to keep pace with inflation. Next, under control system, some recommendations are to include protection of public health and safety as explicit mandate objectives for regulator and distributor and/or retailer, to appoint health and/or safety-focused ministry to oversee alcohol regulation and distribution, to prohibit alcohol sales in establishments such as spas and sporting facilities and via online sales, and to phase out ferment on-premise outlets and at-home brew kits. Lastly, with an alcohol strategy, recommendations are to implement a standalone government-endorsed alcohol strategy or action plan with a wide range of evidence-based public health policies without industry involvement, and allocate dedicated government funding to this strategy with an identified public health leader, an implementation timeline, reoccurring public-facing implementation assessments, and updates at least every 5 years. A best practice example is that the Newfoundland Alcohol Action Plan, which is funded and endorsed by government, has leaders and implementation committee, a set timeline, and evaluation assessments built in. So that's everything we have to present to you today. Thank you again for attending, and we'd now like to open it up to everyone for questions.